Today's today's focus is on Betty, a 74-year-old woman with a prolonged history of high cholesterol, hypertension and a BMI of 31. During her last exercise therapy session, Betty complained of moderate pain and cramping in her left lower leg. We conclude, based on Betty's medical history and the presenting symptoms, that she has potentially developed peripheral arterial disease, or PAD. PAD is a manifestation of systemic atherosclerosis involving all peripheral arteries, but in Betty's case particularly those in the lower extremities. Atherosclerosis occurs when fat or protein cells accumulate on the endothelial layer of an artery, progressively building up and narrowing the arterial lumen, known as stenosis, or eventually occluding the vessel. PAD is distinguished by this partial or complete interruption of oxygenated blood delivery to peripheral tissue, and whilst atherosclerosis is the most common etiology, it may arise from processes including arterial entrapment, thrombus, or embolism. Distinguishing symptom of lower extremity PAD with disease progression is pain in the calf during exertion as a result of arterial stenosis superior to the affected muscle, as clearly demonstrated by Betty. Upon walking, the calf can become cramped, fatigued, painful or numb at a set distance, but these symptoms cease within minutes after the patient rests. Known as intermittent claudication, or IC, it illustrates that the muscle needs less oxygen and nutrients at rest compared to when active. Trademark symptom of IC, a number of factors within Betty's medical history also give strength to my hypothesis that she has PAD. Betty appears to harbour a number of risk factors. Her age. The prevalence of PAD increases with age, with a significant increase seen in those over 65. A BMI of 31 places her in the obese category, commonly linked with higher incidences of atherosclerosis, diabetes, and excessive triglyceride storage. Lastly, hypertension and hypercholesterolemia are both associated with a 2.5 to 5 and a twofold increased risk of claudication, respectively. We know that when muscles cramp and become non-functional, inadequate oxygenated blood supply to the body is somehow compromised, thus prompting us to investigate the role of hypertension and hypercholesterolemia in the development of Betty's PAD, keeping in mind this condition is a manifestation of atherosclerosis. In a healthy, strong, functioning blood vessel, its wall is comprised of three distinct layers or tunics that surround a central blood-containing space, the vessel lumen. The inner two layers are of particular interest. The middle layer, containing elastin and smooth muscle cells, influences circulatory dynamics such as blood flow and blood pressure. The innermost tunica intima contains endothelium, distinguished by flat cells, closely fitted together, providing a slippery and smooth lining to minimize friction as blood moves through the lumen. When dysfunction of the endothelium occurs, key mediating roles including anti-inflammatory, antithrombotic, and as a vasodilator all become compromised and thus contributes to the developing stages of atherosclerosis. Relation exists between hypercholesterolemia and atherosclerotic plaque formation and to endothelial dysfunction as a result of oxidized low-density lipoprotein, or LDL, impairing the endothelium's ability to provide dilation. Hypercholesterolemia can be defined by plasma total cholesterol exceeding 200 mg per 100 milliliters or plasma low-density lipoprotein cholesterol exceeding 130 mg per 100 milliliters. A primary and secondary form of hypercholesterolemia exists. Primary is generally linked with genetic issues, and the secondary form is linked with health and behavioural conditions. Cholesterol is a sterol. It's insoluble in water and transported in blood plasma in protein particles known as lipoproteins. These lipoproteins include LDL, or high-density lipoprotein, HDL. All lipoproteins carry cholesterol, and whilst elevated HDL levels are protective for the heart, elevated LDL is associated with atherosclerosis. LDL transports cholesterol to peripheral tissues for membrane and hormone synthesis or storage for later use. However, when elevated levels are present, potentially lethal cholesterol deposits are laid down in the artery walls, eventuating in narrowed or occluded vessels. Proteins aggregate within the intima and become oxidized by the action of oxygen-free radicals generated by macrophages or endothelial cells. The oxidized LDL is engulfed and accumulated in the macrophages and other phagocytes, which are then known as foam cells, and later form fatty streaks of the plaques of the atheroma in the tunica intima. Considered problematic when they accumulate and create a necrotic center with a fibrous cap, they can impede flow or potentially rupture, causing the formation of a clot and obstructing blood flow. Modification to the endothelium's function and morphology is also indicative of hypertension. Defined as blood pressure persistently at or above 140 over 90 millimeters mercury, is usually asymptomatic for the first 10 to 20 years, slowly but surely straining the heart and damaging the vessels. Obesity is an important identified risk factor for hypertension because it contributes to several processes, especially endothelial dysfunction. Hypertension is caused by an increase in the cardiac output or vascular resistance, and blood flow is determined by two factors, pressure and resistance. Recalling Pasquale's law, we know that if a vessel radius is reduced by 50% by, for example, the formation of an atheroma or loss of vasodilation function, a 16-fold increase in resistance to flow can be observed. Thus, a small change in vessel radius leads to an increased resistance and hence decreased blood flow. Structural changes in hypertensive vasculature show similarities to those in the heart, including remodeling and hypertrophy, as a result of similarly trying to normalize wall stress from an increase in work demand due to pumping against a resistance. It is also known that flow affects arteries via the frictional force experienced by the wall as a result of the flow of blood. This wall shear stress is identified by endothelial cells, who release a number of vasoactive factors that affect arterial tone and growth. Diminished nitric oxide, which acts as a vasodilator and inhibits growth and inflammation, plus oxidative excess, elevated homocystinemia, and altered insulin signaling all correlate with endothelial damage in hypertensive patients. These factors contribute to impaired vasodilation associated with hypertension, which further attracts and accumulates cholesterol and exacerbates the process of hypercholesterolemia, marking the early phases of atherosclerosis. Symptoms may vary between patients with PAD, but in Betty's case, insufficient blood supply to the legs causes pain when walking or intermittent claudication in the calf due to the direct influence of prolonged high blood pressure and cholesterol levels on particularly endothelial function. Diagnosis of PAD is critical for preventing cardiovascular events and necrotic tissue down the track for Betty. Upon presentation to her GP, I would anticipate a number of clinical assessments to be performed to help establish Betty's condition. Commencing with a simple foot inspection, having Betty remove her shoes and socks to facilitate a foot inspection allows the colour of the skin, temperature and integrity, loss of distal hair, and the presence of muscle atrophy and trophic nails to be observed. Moreover, palpation and oscillation of the peripheral pulses may reveal a weak or absent pulses potentially signalling PAD. Most importantly, the presence and severity of PAD is commonly measured by the ankle brachial blood pressure index, or ABI, to gain insight into the quality of flow in the lower limb. It's defined as systolic blood pressure taken at the ankle divided by systolic blood pressure at the arm during supine rest following treadmill use or walking stairs. Typically, abnormal values of less than or equal to 0.9 are indicative of PAD, whereas borderline may be in the range of 0.91 to 0.99 and normal 1 to 1.4. Resting ABIs may be normal in patients who have PAD with symptoms of IC, thus it's ideal to measure ABI straight after exercise. During exercise, the arteries dilate and will lower blood pressure to the legs, especially if arterial stenosis exists, causing a lower ABI. In Betty's case, we would expect with intermittent claudication occurring during exercise an ABI of about less than 0.8. If the disease was more advanced than what I'm led to believe, Betty would experience pain at rest with a severely reduced ABI or may begin to develop ischemic ulcerations of the lower extremities. Non-invasive tests that can confirm the diagnosis include Doppler ultrasonography and measurement of post-occlusive reactive hyperemia, or PORH. Gardner and Afark state that PORH relies on the inflation of a blood pressure cuff to temporarily interrupt flow at the upper thigh or knee. Then measurement of systolic blood pressure is obtained at the ankle or calf seconds after releasing the occlusion. Lower post-occlusive ABI and delayed return to pre-occlusion pressures is indicative of PAD. Additionally, if Doppler ultrasound is used in conjunction with occlusion, the Doppler signal should be lost if the cuff inflation reaches 200 mm mercury and fails to stop the Doppler signal. It suggests a calcified arterial wall not capable of being compressed. The ABI will be unreliable due to these non-compressible vessels, and other methods should be utilised, including the toe brachial index and magnetic resonance angiogram. Claudication will ultimately impair Betty's walking ability as a direct result of the failing peripheral arterial system's inability to deliver oxygenated blood to the active leg muscles. Progressively, this can create difficulties for her in performing her daily activities, putting her at risk of becoming housebound or losing her independence. Needless to say, Betty's quality of life will become diminished. She may become deconditioned and her hypertension, high cholesterol and weight status may become worsened. With this in mind, primary treatment goals for Betty must focus on decreasing cardiovascular morbidity and mortality to improve quality of life and to improve limb-related symptoms, that is, claudication. Improving ambulatory ability or increasing walking distances to onset and to maximal claudication is particularly the key goal for exercise rehab. Diagnosis of PAD can lead to the more prompt detection and treatment of other comorbid conditions, thus potentially preventing complications in the future for Betty. A multifaceted approach to her healthcare ensures that management of risk factors such as hypercholesterolemia and hypertension are not neglected and ensures long-term risk reduction is prioritised. Betty's GP will be responsible or perhaps a nurse practitioner can provide Betty with education surrounding self-management skills and motivate her to modify behaviours to cope with PAD and the existing conditions. This may involve monitoring blood pressure at home, advising of appropriate footwear, encouraging proper foot care, including daily foot checks to decrease the risk of ulceration, and teaching Betty about what signs require immediate attention. Betty's GP will be responsible for the direct treatment of a PAD and IC via the prescription and management of pharmaceutical agents, including peripheral vasodilators, pentoxifillin and or silastazole. Both are phosphodiesterase inhibitors that cause decreased blood viscosity and increase the flexibility of red blood cells, enabling easier flow through narrowed vessels. However, evidence of the effectiveness of pentoxifillin is still unclear, so the newer preferred silastazole is used. It improves claudication symptoms and increases walking distances by about 40 to 60% up to 3 to 6 months of therapy. Silastazole should be avoided in patients with heart failure due to its role in fluid retention and increasing ventricular arrhythmias. Thus, Betty's GP must take this into account. Antiplatelet medications such as aspirin and clopidogrel can be prescribed to patients and is proven to interfere with platelet function or blood clotting. It also reportedly reduces the risk of MI, stroke and vascular death in individuals with symptomatic PAD, that is, those like Betty suffering IC. Statins effectively reduce LDL levels by decreasing cholesterol synthesis, increasing LDL receptors and increasing LDL clearance. Their use hopefully reaches desirable levels of LDLs being less than 100, or for patients like Betty with lower limb PAD with a very high risk of ischemic events, a target of less than 70 milligrams per deciliter. Antihypertensive therapy is also essential for the control of Betty's hypertension. ACE inhibitors such as captopril aim to reduce Betty's BP to approximately 130/80 millimeters mercury and potentially cut her risk of cardiovascular ischemic events. Ultimately, the strategy with the greatest efficacy for improving IC proves to be pharmacological interventions combined with exercise rehab program. With the guidance of an EP, engage in exercise over 2 to 6 months in the form of walking beyond the onset of pain for as long as the individual can tolerate, aids the efficient supply of blood to the muscle upon demand during activity. Supervised exercise program should consist of at least 30 to 45 minutes, 3 days a week, to eventually increase the distance a patient can walk before experiencing claudication. Improvements in walking distances to onset and maximal claudication pain following exercise rehab can be attributed to enhanced flow and redistribution of flow to the exercising musculature and improving walking efficiency. Plus, Betty may gain enhanced muscle efficiency via adaptations including muscle hypertrophy and improved endothelial function. Nutritional counselling provided by a qualified dietitian may address the nutritional influences associated with Betty's lifestyle conditions. Her diet may be modified based on the recommendations outlined here, which suggest reducing intake of saturated fatty acids as well as including enhancing LDL lowering alternatives such as plant sterols and increasing soluble fibres. Participation in regular activity promotes energy expenditure and maintenance of an optimal body weight, that is a BMI of 25 or less. With the support of these professionals, Betty has the opportunity to actively participate in risk reduction, reducing body weight by 5 to 10%, reduces total cholesterol by up to 18%, LDL by up to 22%, and increasing HDL by up to 27%. Research has also shown that a single bout of resistance exercise for patients with IC showed reduced systolic, diastolic, and mean BPs immediately after, indicating cardiovascular load may be reduced with training for people like Betty. Moreover, a correlation of a one-to-one drop in blood pressure with weight loss is said to exist, clearly indicating the importance of losing weight and achieving an optimal BMI for Betty. Reducing Betty's risk of cardiovascular events depends on ongoing input of these skilled practitioners, their ability to communicate effectively with each other and provide support to Betty from all angles. By developing good quality relationships with each professional and being open to gaining a clear understanding of her disease and its processes, as well as treatment outcomes, Betty can develop the necessary skills to cope with POD. By optimising her walking ability, providing relief from symptoms and reducing further risks and complications, Betty's quality of life and longevity can profoundly be improved.